My name is Chris Patriquin. I'm a hematologist in Toronto, Canada at the University Health Network, and I'm a current chair of the Canadian PNH Network. So we have a group across the country that tries to provide expert care for this ultra-rare disease. So PNH is an acquired non-malignant clonal abnormality of hematopoietic stem cells. So there's a mutation that happens in the X chromosome of blood stem cells that leads to an absence of what are called GPI anchors on the surface. And these anchor proteins are important because they can bind various effector molecules, and two important ones in the context of PNH are complement regulatory molecules called CD55 and 59. And when they're absent, it puts the blood cells at risk of damage from the complement system, which is a natural part of our immune system, but typically our cells are protected, but in PNH, they're not. So this can lead to blood cell breakdown in the context of red blood cells. That's hemolysis, and anemia can occur. This also happens on the surface of platelets and white blood cells. And when that happens in concert, that can lead to an increased risk of blood clots or thrombosis. So standard of care in most parts of the world, and really since approval of eculizumab in 2007, has been C5 inhibition. So that's blocking the last part of the complement system, the part that forms what's called the membrane attack complex. And so in most parts of the world where complement therapies are available, that's the first line therapy for most people. There are novel therapies that have been approved over the last few years, and in some jurisdictions, you can use those up front as well, and they target different parts of the complement system a bit earlier on. But in most places, it's a C5 blockade. So similar to the combination that we used in this trial, but eculizumab and what's more recently approved ravulizumab and crovalimab are the other therapeutics that block C5. Yeah, so the Access One trial has essentially two cohorts, and we reported on cohort A, which is more the exploratory cohort, and that randomized patients one to either ravulizumab, which, as I mentioned, is a standard of care in many parts of the world now, to the combination experimental arm, which is pozelimab, which is also a C5 inhibitor, and what's called cemdisiran, which is a small molecule inhibitor of RNA. So it actually blocks production of C5 in the liver. So the combination was felt to be able to do two things. One was allow for a less frequent and lower volume delivery of pozelimab, the monoclonal antibody. And with blocking actual C5 production, you get a more kind of uninterrupted and durable drop in C5. And so patients were randomized 1-to-1 for this and observed for 26 weeks. And we looked at primarily hemolysis control, looking at a surrogate called the LDH, lactate dehydrogenase. What we were able to see over the 26 weeks primary analysis period, and there was also some data from the open label extension phase, we saw that patients who were treated with the combination had deeper C5 suppression, deeper control of their terminal complement activation, and a typical or a common ratio that we look for in managing patients with PNH is to have an LDH below 1.5 times the upper limit of normal. Below that threshold, there's a lower risk of thrombosis and other end organ complications and even death. And in the cohort that we saw, that was achieved in 96% in the experimental arm who received the combination of Poze-cemdi, and 80% in the ravulizumab arm. We also looked at full LDH normalization, so not just below 1.5 times the upper limit of normal, but full normalization, and we saw a higher rate of that also in our combination Poze-cemdi arm, 93% versus 65%. Yeah, so the take home is really that there is this combination of therapies is a viable option for blocking C5 and treating PNH patients. It's similar to what we've seen in previous therapies. It blocks C5, but this has It's rapid. It shows a bit more control without sawtoothing to suggest maybe a loss of control nearing the end of dosing schedules. And the other benefits here are that really there is an opportunity because this is subcutaneous to be a small volume delivery mechanism that patients or caregivers or family members would be able to do themselves instead of needing an intravenous infusion, which is what the current ravulizumab and eculizumab require. The registration component of this trial will continue. We've been enrolling now for quite some time, and that's comparing the combination again, but now to eculizumab, not ravulizumab. So that's cohort B, and that will be the one really that would contribute to registration and regulatory submissions. And of course, all the patients that have enrolled so far have most have gone into the open label extension phase, and so we're monitoring their outcomes over time as well, because all of those elect to go into the open label extension, switch over, or continue the Poze-cemdi combination. So it's just going to provide us more maturity of data over time. The other piece to point out is with the target that pozelimab has, it blocks C5 at a slightly different moiety or binding site. And there has been some concern in the literature about when you transition a patient from one C5 inhibitor to another, you can effectively cause what are drug target drug complexes. So you've got the drug binding to C5 on one side and then on another, and that can precipitate and lead to hypersensitivity reactions. And what we were pleased just to see with, at least so far in cohort A, was that there were no reports of this. And I think that also goes back to the fact that there's a graded transition for patients, and the cemdisiran, by blocking the C5 production very low, I think reduces that likelihood. So we're pleased to see that from at least from a safety signal as well.